Good morning, good afternoon, good night. My name is Hugo Araújo. I am a medical student in Brazil, and today I'm going to talk about chronic pulmonary disease. Chronic pulmonary disease is a condition present worldwide. You can you can see cases all over the countries, but this condition is more common in patients with a long history of tobacco smoke or any other kind of smoking. Besides tobacco smoking as a risk factor, you also have indoor and outdoor air pollution. So, um, people who live in countries with high air pollution rates have a higher risk for COPD. Besides that, you could also identify genetic factors such as alpha-1 antitrypsin deficiency. There is a condition that I'm going to talk about a little bit more later. And another pulmonary condition such as asthma is another risk factor for developing COPD. And of course, age. Age is another risk factor. Danger, it is more common in females due their lung physiology different than the male ones, so they have a higher risk. So, important question you need to do to your patients when you're suspecting COPD are the smoking, how much smoking they had in their past life. You can usually use calculate the relation of packs per year of that patient because usually COPD patients have more than 40 packs year relation of smoking. To calculate that pack year smoking, you need to multiply the number of packs of the cigarettes that the patient smokes. Each pack has 20 cigarettes, and you multiply times the years of smoking. You need to suspect COPD in patients, usually older patients, that tell you that I having chronic cough or sputum production. Usually these are the first symptoms that the patients must are going to tell are going to complain about. Besides dyspnea is another dyspnea when they are exercising or even taking a walk. This this part of anamnesis is really important to classify the patients and to choose the better treatment possible. Besides the symptoms I talked about, it's also important to ask if the patient has recurrent airway infections or exposure to risk factors. So you need to ask to your patient if they have recurrent pneumonia or any other airway infection because that those conditions are more frequent in COPD patients. And risk factors, you need to ask their history of smoking or the exposure in work to pollution, for example, or any other lung disease. The diagnosis is made with clinical features but also with spirometry. Spirometry is mandatory, so to diagnosis, the more important parameters you need to be aware of are the forced expiratory volume at 1 second, which is FEV1, and the forced vital capacity. You're gonna rate, we could put one above the other, and we're gonna calculate the relation between them. So a relation F FV1 FVC relation lower than 0.7, which could also be represented as lower than 70% of prediction. Prediction means the value there a normal patient with the same age and gender have with the results of their spirometry. Please note that it's important to evaluate these parameters before and after a bronchodilator test. So the patient takes the spirometry before taking an inhaled bronchodilator and after. COPD is different from asthma because it has low response to bronchodilators. So you're gonna have to test your patient before and after a short bronchodilator inhale. Important thing to say is that when patients should be screened for alpha-1 antitrypsin deficiency. As I told you, is a risk factor for developing COPD, especially in younger age. Well, World Health Organization recommends that all patients with diagnosis of COPD should be tested for alpha-1 antitrypsin deficiency. But another reference stands for only testing patients with high prevalence of this condition, or if COPD is diagnosed in patients younger than 45 years old. Another important thing to discuss is the differential diagnosis. The differential diagnosis would include asthma, congestive heart failure, bronchiectasis, tuberculosis, obliterative bronchiolitis, and diffuse bronchiolitis. Important thing to notice that asthma is usually present since younger age, different from COPD that usually appears at older age. Congestive heart failure, you could have also changes in heart auscultation or even the presence of edema. So you need to perform a good anamnesis and physical exam to be sure of your diagnosis, and of course with the use of spirometry to be sure. The COPD can be classified uh, according to the spirometry. GOLD, GOLD 1 to 4. GOLD 1 is a mild case with, with a prediction higher than 80%. GOLD 2 is a moderate with a forced expiratory volume on 1 second, lower at 80% and higher than 50%. GOLD 3 is a severe case with a forced expiratory volume lower than 50% but higher or equal to 30%. A GOLD 4 is a very severe case with a forced expiratory volume of 1 second lower than 30% of prediction. This is really important to classify your patients, and after you have classified them according to their spirometry, you could assess their symptoms. The assessment of symptoms is made with both of these tools. You could use one or the another one. The first one is a modified British Medical Research Council, and another one is a COPD assessment tool. I have brought here the Modified British Medical Research Council as an example because the COPD assessment tool is a little bit longer. You can check that on internet. You can have some calculators to calculate that. So this one here, you're gonna have 4 levels of symptoms. Level 0, yes, I only get breathless with strenuous exercise. So this here is common for any regular patient. If you have strenuous exercise, you're gonna get breathless. So we don't need to worry about so much. First one, level 1. I get short of breath when hurrying on the level or walking on a slight hill. Level 2, I walk slower than people of the same age on the level because of breathlessness or have to stop for breath when walking at my own pace on the level. 3, I stop for breath after walking about 100 yards or after a few minutes on the level. 4, I'm too breathless to leave the house or I'm breathless when dressing. So the 4 here, level 4 here, the fourth level here, you can see that is the most problematic level. Even if they are resting or in short exercising, they get breathless. The assessment of symptoms is important to classifying them according to this classification. You're going to classify the patients in A, B, C, D. First, in this line, you're gonna put the patients in the first line or in the second line. The first line is the patients that had 0 or 1 exacerbation for the last year, but no leading to hospital admission. So if that is the case of your patient, he's whether A or B. If they had, if the patient had a hospitalization in the last year or 2 or more exacerbations for the last year, he's going to be a COD. When you have put the patient in the first or second line, you're gonna put the patient in the first or the second column. And for that, you're gonna use the assessment tools that I told you about in the last slide. So you're gonna classify them according to the modified British Medical Council. If they have 2 or higher, as you can see here, is already going to be a B or a D. Please aware that the D have a more problematic prognosis than the other ones. So the treatment of COPD is divided in general treatment, outpatient therapy, and exacerbation therapy. The drugs that are usually used are bronchodilators of short action or long action. And I'm gonna say a few of them for you. As you can see here, I have the beta 2 agonist. You have short acting B2 agonist, as for example phenylterol, levoterol, salbutamol, and terbutaline. And you have the long acting beta 2 agonists, as are formoterol, indacaterol, olodaterol, and salmeterol. And you also have anticholinergics. The short-acting anticholinergics would be ipratropium, and oxtropium. The long-acting would be aclindium, glipopyrronium, tiotropium, and umeclidium. As you can see here, I have highlighted the more common drugs used in this condition. The general treatment of COPD includes smoke cessation. This is really important for patients. Uh, it is also important to vaccinate against influenza and pneumococcal infection. The frequency of these vaccines must be evaluated by the recommendation of each country. Okay, and pulmonary rehabilitation that could be done for physical therapies, respiratory physical therapies that could help with exercise to try to not lose more lung function. The outpatient treatment is going to depend the classification of the patient. You can treat the patient according to their classification here. For example, an A patient, you can use a bronchodilator. The B one, you can use a long-acting bronchodilator that could be a beta-2 agonist or anticholinergic. The C one, it is more recommended to use an antimuscarinic, anticholinergic, sorry, bronchodilator. The D one, you usually gonna have to associate the drugs, anticholinergic and a beta-2 agonist, or if the patient have a blood eosinophil count higher than 300, you could associate an inhaled corticosteroid. The treatment must be assessed, reviewed, and adjusted when necessary. For example, the use of inhaled corticosteroid must be reviewed anytime because usually this treatment could bring side effects to the patient. So you could it is important to deescalonate this patient when possible. So azithromycin can be used in former smokers with persistent exacerbation. So if you have the patient with a good therapeutic management, but the exacerbations are still a problem for them, and he is a former smoker, you can associate azithromycin as the long treatment for COPD. Oxygen therapy is is used for about 15 hours per day when patients then have signs of arterial hypoxemia. For example, patient with oxygen pressure lower than 55 or patients who have shown oxygen saturation lower than 88%, or if the patient have oxygen pressure, oxygen partial pressure lower than 60 and higher than 55. When the patient has a heart failure or indicating erythrocytosis. So if the patient has a partial oxygen pressure lower than 55 or oxygen saturation lower than 88 or a partial oxygen pressure lower than 60 and higher than 55 associated with a right heart failure or erythrocytosis, the patient has indications to oxygen therapy. The treatment of exacerbations include the the treatment of mild, moderate, and severe cases. A mild case, you could use a short-acting beta-2 agonist. A moderate case, you could use a short-acting beta-2 agonist associated with an antibiotic and or a systemic corticosteroid. In a severe case, you're usually gonna use the same drugs as the moderate, but you're gonna have to hospitalize this patient. Then, if an acute respiratory insufficiency is identified, the patient requires ventilatory support. Be aware that non-invasive respiratory therapy is preferred over invasive therapy in the initial management. Okay, these are the reference. I thank you for watching. I'm sorry for any mistakes I have made. If you have any suggestions, please give a comment down below.